This podcast is for educational purposes only and does not provide medical advice or create a doctor-patient relationship. Please do not rely solely on this discussion. Always consult your own healthcare provider and verify information independently. If you're in crisis or experiencing a mental health emergency, call 911 or go to your nearest emergency department.
So, Dr. Cesia Quintero is a family physician and GP psychotherapist practicing in Kingston with a background that bridges the arts and sciences. Dr. Quintero holds a degree in literature and mythology of Greece, Rome, and the ancient Near East from the University of British Columbia. She completed medical school and residency training at Queen's University in Kingston. This foundation allows Dr. Quintero to approach mental health with a dual lens, combining evidence-based medicine with a deep appreciation for the stories and narratives that shape the human experience. With that, a huge thank you, Dr. Quintero, for joining us on today's podcast, really talking about your experiences as a family physician in the community of Kingston and your additional training as well in psychotherapy, which is quite unique. So, what inspired you to pursue this additional training in psychotherapy alongside, I would imagine, would be a really busy family practice as well?
Yeah, well, I went into family medicine because in medical school, my two favorite rotations were psychiatry and internal medicine. And so my thinking was, how could I marry both of those? And so family medicine seemed like the answer. And I also like longitudinal care and, preventative care. So it was the right answer for me. I didn't know that GP psychotherapy was an option. That pretty early into my residency, I heard about it and I sort of started asking around and I was like, oh, this sounds great. I feel like I would really like that. So I did. And then I had my first elective in psychotherapy and I was sort of like sold. I was like, this feels so much more satisfying to me than medication prescribing or a lot of the other things that we were doing, which are important parts, that of course I do as part of my practice, but just the idea of getting to the root cause of the mental health symptoms was a lot more satisfying to me. So I just did a lot of additional training throughout my residency. And then of course, after my residency, I continued doing additional training in psychotherapy and kind of getting experience in different styles of psychotherapy. So yeah, I started kind of doing 50-50 psychotherapy, family medicine. Actually, I started with a third of psychotherapy, and then it's just sort of grown bigger and bigger so that now it's the vast majority of my practice is psychotherapy at this point.
Fantastic. So how did you become specifically interested in personality? You had mentioned to me before that you had a special interest in personality disorders and dissociative disorders.
Yeah.
Now, personality disorders can be quite challenging in terms of countertransference. So could you just explain in simple terms, what does it mean? What does countertransference mean? And how did you become interested in these two type of modalities? In addition to, I'm sure, other things that you're doing.
Yeah. Countertransference, my understanding of it is it's how I, as the provider, feel when I've got a patient in front of me. And a portion of that might be what I'm bringing, the lens that I have, my own life experiences put a lens on me. And some of that might be sort of a more on a therapeutic level, my response to the patient and kind of, do they subconsciously want me to play a particular role in their life? So yeah, it can be challenging in terms of countertransference sometimes. I've always had something in me that wants to go for, like the underdog. And it was pretty clear to me early on in my training. My first medical school rotation actually was in psychiatry. And I could see that there was a lot of stigma from, unfortunately, other healthcare providers to patients with personality disorders. There was something in me that was like, I want to understand this more. And also the fact that approved treatment is usually not medication-based, but psychotherapy-based is kind of interesting. So I think it started more of like there was a willingness for me to work with people that other people don't want to work with, if that makes any sense. With dissociative disorders, it came sort of accidentally. The more I started seeing patients, the more I realized that they would tell me about these symptoms. And then I had this patient that I'd been working with for a while who ended up having dissociative identity disorder. And I had maybe like a moment of I'm going to have to learn something new, because we've been working together for 2 years at that point.
Mm-hmm.
It took me that long to realize that that's what was going on for this patient. And so I had to get a lot of, additional support and training to learn how to work with that patient. And then, so there's a spectrum of dissociative symptoms, of course. So it just kind of came out of necessity. And I find it fascinating. I really do, because I get to do parts work with dissociative patients, and I really like parts work.
It's a lot of work, and it's deeply satisfying work when you're helping somebody with personality disorders, where they have undergone years and years and years of trauma, not being understood, that intense emotional dysregulation to abandonment. So how do you protect yourself from burnout with these kind of cases?
My primary role as a provider is to regulate my own emotions. And that is what helps the patient contain themselves. Of course, there's also the therapy, component of it, and skills and all of that. But if I am having emotions in response to the emotions that they are having, then that, by me saying, you are not too much, I might be the first person in their entire lives that has said, you are not too much, your emotions are not too much, we can deal with this. So I really just kind of focus inward. A wise person told me the first rule of therapy is the therapist must survive. And I tell that to myself every day on a daily basis, several times a day sometimes. So yeah, it's just like a lot of checking in with myself on how I'm doing and how deep I'm willing to go today with this person. And if they're having a lot of pain, and regulating myself, and a lot of kindness to myself. And then other than that, I have to say, I don't find it particularly draining, I think, in the way that a lot of other people might. And that might just be like a me thing. I'm not really sure. In itself, someone being really dysregulated doesn't scare me, if that makes any sense. So I don't find it particularly draining. And also, I know, like I've at this point worked with enough patients for long enough that I know that we're going to get to a really good place in all likelihood. And the pain that they're in today is not the pain that they're going to be in a year. I'm teaching them to see the pain that they're in as temporary, not as permanent. And then I'm also looking at it that way. So that kind of helps me get through those difficult moments that sometimes come up.
I think perhaps one of the reasons why you don't feel that degree of burnout, that when, for example, residents in psychiatry, sometimes their training involves a lot of emerge work. Working in emerge, and a lot of patients in emerge can have personality disorder. They're in intense crisis, and perhaps having a short period of time to be able to assess, determine pressures of beds as well, whether to admit, whether not to admit, whether it's therapeutic to admit or not. Sometimes that perhaps can add to some of that burden as well.
Definitely, yeah. I mean, I remember having a ton of burnout. And I would call it moral injury when I was in training. And a lot of it was because I was participating in a system that my values did not align with. And the way I've set my practice up right now, I'm really practicing in a way that aligns with my values, like what makes sense to me, my humanity. And that really is protective against burnout. The main problem I'm running into right now, I think, is just having, like, I keep getting referrals, and my list has been officially closed for over a year at this point. But I'll take someone who's in a really dire situation, or who's really in crisis, and their family doctor might sort of ask for a favor. So my list is not really opening up, and so I'm kind of running into the problem of, okay, the work I'm doing is deeply satisfying. It's very helpful for the patients. It brings immense value to my life every day. But it's not the most efficient in terms of the amount of people that would benefit from this kind of work. So kind of balancing that is that's probably my biggest source of burnout right now.
Okay. So you've got significant training in terms of psychotherapy, plus you're a family physician as well. For other family physicians who may not have that degree of training, what kind of signs should other clinicians look for when these type of disorders are present in terms of personality disorder or dissociative disorders if they come into primary care?
Countertransference. So if as a physician you're feeling really pressured or really like there's an urgent need to do what this patient is saying, I'd say just any really strong feelings in response to a patient, that could be a sign that there's a personality disorder. This isn't what the DSM says, but I think of personality disorders as just complex trauma, like all of them under the umbrella of complex trauma. So, the next step would then be to say, this patient probably has been through a lot in their lives so that they have developed these ways to survive that are now manifesting in these behaviors and experiences, if that makes any sense.
Yeah.
So that might be one. Someone who is struggling with suicidality, chronic suicidality. So it's not just they're going through an acute problem in their life, but that, they say, I've wanted to die every day since I was 7 years old. That's not diagnostic for a personality disorder, but it, would put that on your radar. Someone who seems to have a lot of big ups and downs, as well as someone who's really struggling interpersonally.
Right.
I think, I've learned that one of the biggest hallmarks of trauma is that it causes disconnection in us. And so someone with complex trauma who's been through a lot will have a lot of difficulty with establishing connections.
I've seen one, sorry to interrupt, but I've seen some cases in which cases that seem like a bipolar 2 disorder, in which the patient presents with depressed mood and hypomanic episodes, almost mimics a personality disorder. They don't, I get referrals where there's a question whether it may be bipolar 2 or not, but a lot of the cases, those hypomanic are usually in reaction to more social interpersonal stresses. Yeah.
That makes a lot of sense. Do you think that bipolar has a trauma-based origin? Like if we really look at the origin of the symptoms?
That's a really good question. You see, when you're looking at bipolar disorder, what triggers it, we talk about the formulation, we talk about the biological, psychological, social causes that can trigger a person to have bipolar disorder. So is there a trauma base as a precipitant, perhaps? But were you thinking of something more underlying in terms of the expression of mania and trauma?
I think so. The more I learn about mental health, the more I'm thinking it's all trauma. Like, if you dig deep enough, it's all trauma. As Gabor Mate would say, big T trauma or little t trauma. Right. So what we typically think of as trauma, or just an accumulation of situations that we didn't have the coping mechanisms to deal with, so they become trauma, even if they wouldn't necessarily be trauma to someone else.
I think, there's definitely an element of that, but people who've had depression, sometimes when I describe the biological, psychological, social aspects of their disorder, I try and say, look, the idea of taking a full history is to try and ascertain subjectively what proportion of their illness is biological, what proportion of it is psychological, and what proportion of it has a social basis to it. And therefore, accordingly, you provide a biological medication intervention, a psychological talking therapy intervention, and then other social factors, maybe taking some time off work to allow for recovery. Does trauma perhaps thread entirely through that process? There could be a strong argument for that. Trauma is no doubt a constant throughout a lot of these disorders. But again, I have to look at them somewhat categorically as well. Trauma, I think, is perhaps overlooked a lot of the time. And I think perhaps that's a key thing.
Trauma gets overlooked as underlying or perhaps being expressed through something like psychosis or mania.
Yeah. And in one of our previous podcasts, we talked about accelerated resolution therapy. And honestly, when you talk about small t traumas, big T traumas, again, trauma being on a spectrum, I think a small t, big T trauma is not just about the trauma itself, it's the subjective experience of that trauma. Yeah. So whereas one individual may experience a car accident and really walk away fine without any kind of trauma related to that, another individual may experience the exact same type of accident, but experience PTSD as well. So it's a very subjective thing as opposed to just a category of trauma.
Yeah, it's not what happened.
It's not what happened, but how they experienced it exactly. So, what therapeutic approaches do you use most often with these type of patients with personality disorders and dissociative disorders?
So, dialectical behavioral therapy is sort of first line in terms of treatment. Unfortunately, it's very hard to get dialectical behavioral therapy in Canada and in the system that we have here, because ideally everyone would have an individual therapist as well as group therapy as part of their treatment. That's how it's supposed to be set up. So I I've only just started having the group therapy, which is very exciting. So now I can sort of provide both for a small set of patients. So yeah, I do a lot of dialectical behavioral therapy.
Just to interrupt, if you don't mind.
Yes.
Just for a person who doesn't know what it means, what does it involve in simple
Dialectical behavioral therapy is a second wave. So it's sort of based on CBT. It's got the same principles
Cognitive
in
behavior
cognitive
therapy,
behavioral therapy as our thoughts, our behaviors, and our emotions are all linked. They'll influence each other, and if we change thoughts and or behaviors, we can change our emotions, which is our emotions are the source of our suffering. So it works on that basis, but it is very diverse in terms of its principles. So it teaches about mindfulness, so being in the present moment. It teaches interpersonal skills. It teaches emotional regulation, which is how to regulate your emotions, and then distress tolerance. So what to do in a moment of an intense crisis, how to quickly bring yourself down without doing anything that you might later regret or that might cause harm to you or others. So that is, so those are sort of the four principles of it. So I do a lot of dialectical behavioral therapy. And then I end up doing a lot of more psychodynamic work. So parts work, kind of like in the internal family systems vein, or inner child work, whatever makes most sense to the patient, however they want to frame it. And that is the most powerful technique that I know right now to get someone to a much better place quickly, because things like DBT teach very, very good, very valuable skills, but it's not really getting at the source of the pain, right? The part of you that's been ostracized or that is holding that pain. So I do that, and I do some like somatic experiencing and just learning to sit with the pain and then learning to regulate the emotional pain. So I'd say those are probably like the biggest. I'm sure I'm forgetting something that is really important to me that later I'll be like, oh, I forgot to mention that. But that's sort of what's coming to mind in terms of what I use.
That's great. No, that's really valuable. So what advice would you give to family physicians, early career clinicians who feel quite overwhelmed with managing personality disorders or dissociative presentations?
Yeah. So the first advice I would give, I'm struggling with this one because I know how hard it is to be a family doctor, and I know that there's not a lot of time, but really some education around it, because I find that in someone with a personality disorder, a lot of things are dialed up to the maximum volume. So, emotions are dialed up to the maximum volume. The urgency of things is the physical symptoms might be dialed up to the maximum volume, and that can feel very overwhelming. But if we can understand what's actually going on for this patient, and again, like regulate our own feelings about that, whatever our response is to the patient, then to me, it becomes a lot easier to manage. So education around how to interact with these patients in a non-stigmatizing way, and then get very, very good at validation. Validation is such an important tool for someone with a personality disorder. And I find that often, if someone comes in and they're really distressed about an experience that they just had an emerge, the automatic response might be, why are you attacking my system? Why are you attacking the doctor? I can relate to the doctor because I'm a doctor too. And so that can bring up really difficult emotions. But if we can just validate that was really hard for that patient, for whatever reason, that's no one's fault. It may be the system's fault, but other than that, no one's fault. Then like we can always agree that their emotions are their emotions. They're that intense.
I think that's the fundamental thing I provide with my patients as well, is that if I don't have the answers, validate. At least make them feel better leaving than when they first came in.
Yes. Yeah. Validation. And validation can be such a healing thing in itself. Because one of the root causes of personality disorders, well, specifically borderline, I don't want to lump them all in, but is chronic invalidation.
Correct.
So it is really important too.
And they're also on a spectrum. You have some very high, I mean, I've seen a number of patients, fairly high functioning people with borderline personality traits, bordering on disorder. And, I've had quite a bit of success referring them to Providence Cares. They have a community DBT, I think, group as well. So there are some things out there, but perhaps I think some work I'm thinking just from this discussion is really how do we try and interlink the different services out there in a more cohesive way that's easy to understand, knowing what the services are out there and what are the key criteria for referrals that way. Any last words for other people who may be struggling, thinking that they may have a personality disorder, or they have a loved one who they're concerned about having a personality disorder? So
my first advice would be to just destigmatize it. It's all trauma. So ask yourself, think of it as there's nothing wrong with me or with my loved one. These are the ways that they had to change in order to survive. And because they learned these ways to survive, they can also unlearn them and learn other ways to survive. So, personality disorders are very treatable. There's really good statistics in terms of, at 5 and 10 year outcome measures after treatment. So this is a treatable condition. The primary treatment is psychotherapy, not medication.
Correct.
Medications can sometimes help with some symptoms, but ultimately, finding psychotherapy and realizing that this is no one's fault. They are not a bad person.
Correct.
This is just how they've had to survive. And if they knew another way, they would have found another way. That was just the best that they could do given their circumstances.
Fantastic. Thank you so much for your time, Dr. Quintero. And there's tons of stuff we could talk about, but really appreciate your time and sharing your experiences with us.
Thank you so much for having me. It's been a pleasure. I really enjoyed it.
Thank you.